Hi, everyone. Welcome to another episode of the Rafael Medina Subspecialty Virtual Morning Report. My name is Tin, and today we will have a session focusing on rheumatology. And we have two special clinicians from Johns Hopkins Hospital. And without further ado, I'm going to introduce the first case discussant. He is Michael Cammarata. He's the assistant professor of medicine at the Johns Hopkins University School of Medicine, where he practiced rheumatology and hospital medicine. He has interest in musculoskeletal ultrasound, vasculitis, and medical education. Thank you, Michael, for joining us today. I'm going to just ask you the first question. What inspired you to become a rheumatologist and also working as a hospitalist?
Uh, Great question and great to be here. Thank you for the invitation. Um, I was initially, actually on track to do surgery, believe it or not, and but it was, I realized that the kind of problem solving I enjoyed most was that of internal medicine. And after a great deal of reflection, I realized that all my favorite cases were in rheumatology. And there's a lot I really love about the specialty. The multi-system nature, the longitudinal patient relationships, the importance of the physical exam as well. Pursued the fellowship in rheumatology, which I really enjoyed. And but I didn't want to lose that element of general medicine. Vivek Murthy is a faculty at UCSF, and he actually has a similar split role between hospital medicine and rheumatology. And so he was a great resource. And he says that being a great generalist makes a great rheumatologist, and I think that's very much true. So it definitely keeps things interesting, and I'm always learning. So it's been a lot of fun.
Oh, that's great to hear. So, I have another question for you, Michael. So, nowadays, especially for us physicians and some of the rest of the healthcare providers, we are constantly so busy and we're like moving here and there. So, do you have a go-to self-care activity that you do when after like a busy day of work?
Usually it's some type of movement. It's usually running if I'm not on the DL, and oftentimes it's running with Brendan. And so otherwise, just getting into the gym. That usually does the trick.
That is amazing. Well, my trick is just walking with my dogs. They make me so, so happy. So, yes. So thank you again for joining us. And now for our second case discussion, we have Brendan Devere. He's a second year fellow in the John Hopkins Rheumatology Fellowship. He is currently pursuing a master's in clinical investigation and doing research in the John Hopkins Vasculitis Center. So welcome, Brendan, to the CP Solvers. And for you, I see you're doing a lot of things while you're in fellowship. So, what is your secret to stay organized or stay focused?
I'm not sure I have any secret. I'm happy to be here. Thank you for the introduction. I feel like I'm just muddling my way through life and through medicine just as like everyone else. Um, every day I feel like I'm reevaluating, my clinical knowledge and my organizational skills and things like that. And it's kind of like a lifelong challenge. And I think that's why we all got into this field in the first place. Yeah.
I think being just as calm as you are now, I think that's a secret, even though if you're not telling us. So, as our case presenter, he does not need any introduction. He's well-known member of the CB Solver. So we have Franco Murillo. He's a PGY3 in internal medicine, also chief resident at Sinai Hospital, Baltimore. So, Franco, welcome back to another virtual morning report. So now that you're finishing with your residency, what are you thinking to do in the future? What's your plan? And I think I heard something, so you might share with everybody the good
Hi,
news.
everybody. Yeah, thank you for the introduction. So I'm actually applying to room, so I'm gonna figure out where I land in the next 2 days. So let's see.
I'm sure that in a couple of days we're gonna hear good news. I'm sure, because you have been contributing so much with the clinical problem solvers. We have learned so much from you. So any fellowship will be so happy to have you. Okay, so now I think if we have, let me see if everybody's ready for the start the case. Let me just make co-host some scribe and also let me see here. 1 second. Yes, I think she can share now.
Perfect. Okay.
And yes, I think we can see the whiteboard right now. And I'm just gonna do, yeah, whenever you're ready, Franco, you can start with the first aliquot.
Absolutely. So the chief concern is a patient comes with left periorbital swelling and joint pains. So for the HPI, this is a 77-year-old male who presented with 2 weeks of left periorbital swelling. He reports that actually 1 month ago he had an upper respiratory tract symptoms. They were self-limited initially, like for 3 days. It consisted of productive cough, hoarseness, and intermittent fever. At that time, he went to his PCP because he felt that the symptoms were on and off. And the PCP get him azithromycin and prednisone. After the azithromycin and prednisone, the symptoms resolved. However, 2 weeks before the admission, he reported that he started having left periorbital swelling and bilateral wrist and right knee pain, as well as recurrence of the fevers.
I think this is a good place to stop. Okay, so Michael and Brendan. So this first aliquot with this chief complaint with the left orbital swelling, what do you think of that? It's not something very common that we see in the ED. So when you see it, do you have any type of approach to the eye, like orbital swelling? If so, can you tell us maybe some differential diagnosis also that involve the eye and also some rheumatological condition that you can think of?
Sure, I can start, and then I can pass it off to Michael when I run out of things to say. Yeah, periorbital swelling is an unusual complaint. And the first thing as a rheumatologist that pops into my head is granulomatosis with polyangiitis, but there's other rheumatic diseases and non-rheumatic diseases that can cause this. Focusing on the eye, and maybe I'll put the joints to the side for a second. I want to know more about the periorbital swelling. I want to know if there's redness in the eye. I want to know if there's intact extraocular movements. I want to know how the cranial nerves are working. I want to know how the patient's vision is. If I'm not that good at looking in the eye, every once in a while I'll try to, but nowadays in medicine we rely on our ophthalmologist to kind of get a good look at the back of the eye and tell us what's going on. So in terms of your differential diagnosis, we think that's a good question. Infection, especially, it sounds like this patient had a prodrome, I want to say, was it a month before this periorbital swelling started, 2 weeks before? That's certainly on the differential diagnosis. It can be a bacterial infection, it can be a viral infection, like a orbital cellulitis. And then in terms of rheumatic diseases, I mentioned GPA. There's also IgG4 related disease. Relapsing polychondritis can cause like a chondritis, which can include the eyes. So these are the things I'm just kind of naming off the top of my head, but a lot more information, I suppose, to get out of this patient.
That's great. And I think I'll add that, if I were seeing this patient, I would want to know exactly where the inflammation is. I think that's what Brendan was getting at when he's asking, is there eye redness or the cranial nerves intact? So I think this is a case where, imaging is going to be really important. Is there inflammation along the extraocular muscles or in the periorbital space or in the, the soft tissue? So, something like a orbital myositis is something that we can see in as Brendan mentioned, with things like GPA or IgG4 related disease. Sometimes these are idiopathic, but I think up front with an inflammatory process, excluding infection like an orbital cellulitis is very important, and involving our ophthalmology colleagues is going to be one of our first steps. And I think the presence of joint pain kind of anchors us a little to the possibility of some kind of rheumatologic process. It'll be interesting to see, are we dealing with an arthralgia, right? Where it's just pain without swelling, or is this an arthritis? So a lot of that's going to kind of hinge on the exam and as to whether or not we actually can detect any swelling in the joint, being the actual joint capsule or the tendons around the joint, such as a tenosynovitis. And then we can get a history from the patient to determine whether or not it sounds inflammatory. The presence of swelling seems to suggest that it is, but if this patient tells us that there's warmth, that he notices swelling, and that the pain will actually improve throughout the day with activity, then those are features that suggest an inflammatory process.
This was amazing. So I have some follow-up question to your clinical reasoning. So Franco also mentioned that there's some joint pain, and he mentioned that it was at the right knee pain. For you as a rheumatologist, do you have what do you think when the pain is unilateral versus bilateral? I think there's a lot of things going on when it comes to like management, when the joint is symmetrical versus asymmetrical. Do you have anything to say about that?
Sure, I'll add that there are certain diseases that have a predilection for certain joint involvement. When thinking about arthritis or an inflammatory arthritis in particular, I like to think in terms of categories of disease being infection, and then systemic rheumatic disease, like RA or other ANA positive diseases like lupus, Sjogren's scleroderma. And then we think about the crystalline diseases like CPPD, calcium pyrophosphate deposition disease, and then gout, and then the spondyloarthropathies as well. The two of the most common forms of an inflammatory arthritis are rheumatoid, which tends to be small joint, symmetric, and then also crystalline, such as gout, which can be involve one joint, a few joints, or many joints, depending on usually the duration of the disease. But one category of disease where we often see, oligoarticular involvement, where that means there's just a few joints, and often an asymmetric process, is the spondyloarthropathy. So things like psoriatic arthritis, reactive arthritis, IBD-related arthritis, and then peripheral spondyloarthritis, which we sometimes also see with ankylosing spondylitis. So, I think if there's swelling and we can get knee fluid, we always like that because it allows us to characterize it as inflammatory. That's one thing. It allows us to look for crystals, which is certainly possible in a 77-year-old gentleman. And then it allows us to exclude infection by sending a gram stain and additional cultures, be it bacterial, fungal, mycobacterial.
Thank you, Michael. So actually, I have one more question, I promise, and then we can pass the mic back to Franco. There's a very interesting question in our comment asking the difference between arthralgia, arthropathy, and arthritis. Can you give us that? Because that's a very interesting question as well.
Yeah, sure. So arthralgia, I think, is a more general term just to say that a patient's having joint pain. Arthritis implies that there is pathology in the joint. And it's confusing because we have that arthritis makes you think inflammation, but we also delineate inflammatory and non-inflammatory arthritis. So like inflammatory arthritis would be rheumatoid arthritis, spondyloarthritis, crystalline disease, I guess, kind of. And then a non-inflammatory arthritis would be osteoarthritis. or degenerative arthritis. So arthritis, arthralgia, and then the third one is arthropathy. Arthropathy, I'm not really sure what arthropathy means. It seems like also maybe just a more general term for there's something wrong with the joint. But maybe Michael knows more than me.
No, I agree. I think sometimes we use the term arthropathy when we say like crystalline arthropathy. But otherwise, usually we're saying arthritis or arthralgia. The classic example I would think of with arthralgia would be like if you get, a viral illness and just don't feel well and your joints just ache, like that's an arthralgia.
Thank you both for clarifying those terms. So yes, so Franco, back to you.
Great, I'm loving the discussion so far. So, for prior medical history, the patient had hyperlipidemia, also an episode of pemphigus vulgaris 3 years before this episode. He got actually rituximab times 4 cycles, and his pemphigus vulgaris is on remission, according to the patient. Medication, he's actually only on atorvastatin and occasional Tylenol. No family history, social history, no actually, no travel history, and he was fairly active. Before this episode, he used to run up to 4 to 5 miles weekly. After this episode, he couldn't do it because of the swelling and also the joint pain. No allergies either. And I think I can give you the vitals and the physical and this aliquot too. So vitals, temperature was 39 on admission Celsius, rate 95, blood pressure 130/70, respiratory rate 18, SpO2 96% on room air. So for the physical exam, he didn't look ill. For the hand exam, he did have left periorbital edema, redness around the eyelid, but no pain with ocular movements or secretions. He didn't have any oral ulcers either. Cardiovascular, regular rate and rhythm, no murmurs. Home, continuous air transmission bilaterally. Abdomen, non-tender, non-distended, no visceromegaly either. Neuro-wise, he was Allen times 4. He was noted to have a left foot drop, but no paresthesias. The skin, outside the findings on the eyelid, no other rash, no other plaques either. MSK, he didn't have evident swelling neither in the wrist or the knee. It was just pain with flexion and extension on the right knee, no effusion. And I think I can stop there.
Okay, well, there's some very interesting additional detail that we have here. So, Michael or Brandon, so we started with the patient that Franco just gave us more information about his past medical history, and it looks like this patient already has some autoimmune condition with pemphigus vulgaris 3 years ago, and he's treated with rituximab, which is a monoclonal antibody that is commonly used in rheumatology. Do you think that this picture that the patient is currently presenting could be drug-induced? If it's not, what are the key questions you would ask to rule out this? And I have more questions, but let's start with this one first.
So there is an entity called serum sickness that can happen with rituximab. Rituximab is a chimeric antibody, meaning it has part human and part mouse. And so any monoclonal antibody that we give that has an X in it is a chimeric monoclonal antibody, and therefore it puts you at higher risk of having serum sickness as a kind of drug-related side effect or reaction. This would not be a very typical presentation of serum sickness. You think of, I guess, the joint pain. Yes, an inflammatory joint pain can happen. The periorbital edema, I've never heard of that, but I suppose maybe that's why this case is being presented. So that's possible, and that's certainly on my mind. It's nothing that we can test for, or there's no blood test we can send or anything like that. It's kind of a diagnosis of exclusion. So it's a possibility and something that certainly I thought about right when rituximab was mentioned, but I don't know. I don't know if that's it. Fevers and inflammatory joint pain certainly can be indicative of serum sickness. The likelihood of it happening after 4 doses, I'm also not sure if that's the case, but maybe I can ask Michael for help.
Just to clarify, when did he last receive rituximab?
More than 1 year ago.
Okay.
So
okay.
that doesn't really make sense, right? Yeah.
Yeah.
You'd expect serum sickness shortly after.
And it's very interesting because, well, yes, as Hui-Ting mentioned, like this patient already has, demonstrated that he has, underlying autoimmune disease in the form of pemphigus vulgaris. And sometimes autoimmunity begets more autoimmunity. And the interesting thing, though, is that, for example, in GPA, one of the forms of ANCA-associated vasculitis, rituximab is a very highly effective therapy. So in a patient with arthralgias, periorbital edema, foot drop, that's already quite a good story for GPA, and then it would be interesting that he would have a disease activity despite that. Now it's possible that after 12 months the disease is essentially flaring, or it's possible something else is going on. So that's certainly an interesting component, and when we see patients that have gotten prior exposure to rituximab, we're interested to see if their CD19 and CD20 B cells are suppressed, to suggest that perhaps the drug still has an effect on their system. So it'll be a lab value that, as part of my evaluation, I would be looking at to see what his B cells are up to.
Great. I think that was a very good explanation of why this not could possibly be due to drug, to rituximab. But I heard also from the physical exam, one of the things that stood out to you is the left foot drop. Is there anything else that stands out for the physical exam, or is there any additional findings that you would like to see in order to consolidate some of the differential diagnoses that you already have in your mind?
Well, when I think a foot drop is a unique of enough finding that you can almost build a differential just from that alone. Thinking about, for example, polyarteritis nodosa, one of the medium vessel vascularities, ANCA-associated vascularities that can do it as well, as I mentioned before. Cryoglobulonemic vasculitis can do it, and then other systemic rheumatic disease can as well, in rare instances, for example, lupus or RA. So in the presence of a foot drop, I would want to further characterize that with an EMG nerve conduction study, and then ultimately likely a central nerve biopsy with associated muscle biopsy to see if there is actually vasculitic involvement. You can also have a non-systemic vasculitic neuropathy, but I think that this patient already is, I'm worried already about a systemic vasculitic disease. The patient's febrile, periorbital swelling, and a foot drop. So there's certainly more to go after.
Yeah, this all smells very much like GPA. And then Michael gave a very kind of good differential otherwise for mononeuritis. I don't really have much to add.
I think you both gave us so much information at this point. So I think we are ready to go back to Franco to give us more from the case.
Great, perfect. So there is a bunch of labs coming up. So CBC, hemoglobin of 7, white blood cell count of 13K, 13K, neutrophil 88%, lymphocyte 4.3%, eosinophils 0%, platelets 189K. Creatinine 3.4, the baseline of the patient is 0.8. A repeat creatinine on day 2 was 4, so up from 3.4 on day 2. BUN 67, electrolytes within normal limit, AST and ALT also within normal limits. No increase in bilirubin. ESR 104, high sensitivity CRP of 8. UA, no RBCs, no WBCs, trace protein on the dipstick. Iron 23, ferritin 400, transferrin 128, TIBC 160, B12 more than 2000. Total protein 7.7, albumin 3. ANA 1/320, DNA double strand negative, anti-CCP negative, rheumatoid factor negative, C-ANCA 1/40, P-ANCA negative, ELISA PR3 negative, and MPO negative. And I think I can stop there.
I think you can, Franco, because there's a lot of lab result that we've seen here. And one of the things I noticed, there's some leukocytosis or the creatinine. It looks like the baseline was like 0.8 and now it's like 3.4. It's been increasing. But one of the things that I noticed, and of course, that's one of the favorite thing for rheumatologists is all the autoantibodies. And most of us, we don't understand that. So please, Michael and Brendan, help us to understand how to interpret these lab findings.
Franco, did you have an MCV?
Yeah, just 1 second. MAC 90, MCV 101.
Okay. Okay, so a few things from the labs I can talk about. The patient's quite anemic. Strikingly, that can just be from chronic inflammation. I was kind of glazed over when you were giving me the iron study. So, okay, I see ferritin 400. And it looks like there's low TIBC, but also low iron. So maybe a mixed combination of iron deficiency and anemia of chronic inflammation. The creatinine is also striking from a baseline of 0.8 to 3.4, especially in the context of this patient where we're worried about ANCA vasculitis. You're worried about a necrotizing glomerulonephritis. But the UA sounded quite bland, no RBCs. You know, in the setting of glomerulonephritis, you expect RBCs, RBC casts, blood and protein on a dipstick. Sometimes to also better characterize the protein, we would get a urine protein creatinine ratio. I don't know if you have that, but at least the UA doesn't look so impressive. So still a question as to why this patient has such a bad AKI. The inflammatory markers are very elevated. I think I heard a CRP over 100. And the gamma gap, the albumin minus the total protein, was like 4.7. Which suggests that the patient's hypergammaglobulinemic, also consistent with a systemic inflammatory process. The C-ANCA and the PR3, so this C-ANCA is a test of indirect immunofluorescence. C-ANCA is a pattern on that test that we associate with granulomatosis with polyangiitis. It would be more convenient for us as the rheumatologist. Both the indirect immunofluorescence, the C-ANCA, and the ELISA, the anti-PR3 antibody test, were concordant, meaning that they were both positive. But sometimes this happens where only one is positive and the other one is negative. In combination, those tests kind of give us the best sensitivity and specificity for the disease that we're looking for, in this case, GPA. Sorry if I talk too much, but Michael, you can chime in if there's anything else.
No, it's great. It is the other interesting thing about the rituximab is that it does introduce a little bit of it makes the serologies a little bit less reliable in the sense that, for example, in GPA, oftentimes patients will, the ANCA will eventually become negative, as will the PR3. That bodes well generally for the patient prognostically. In this case, if the clinical presentation was significant enough that I thought this patient definitively had GPA, then we would call them. We would be comfortable probably saying that even in the absence of a PR3. I'm not there yet. I think there's still more data to gather for sure. Absolutely, the kidney injury is very interesting, and I'm wondering if we'll go down the kidney biopsy path. Usually, if the creatinine was 3-4 and there was active urine sediment, you could nephrology would probably be on board to get some tissue. I probably would still involve the nephrology colleagues to see if they could spin the urine and just double check that there really aren't any casts there to suggest glomerular injury. The other thing on the CBC, which is interesting, is I agree the degree of anemia, but then also the MCV is above 100. Common things being common, we think about liver disease, B12, folate deficiencies. But something just to keep in the back of our mind would be a rare form of vasculitis called VEXIS, which is a acquired mutation and a disease that we're beginning to understand and was discovered several years ago. So that's something I'm just kind of parking in the back of my mind. Yeah, still interested to see where this goes. So.
Good. I think we have another question here in the chat that maybe Michael or Brenda can help us to
Sure.
understand this a little bit more. So it is more about the C-ANCA, a positive C-ANCA and negative PR3. What do you think about that? And Mark is saying here that he was taught that P and C-ANCA are for screening testing, and PR3 and MPO are the confirmatory test. So does it make them think that it's a false positive?
Well, I think Michael's point here is really well taken, which is this patient got rituximab, which is an anti-B cell therapy. B cells make antibodies, including autoantibodies like anti-PR3 antibody or anti-MPO antibody. So in a patient who's gotten rituximab, measuring those antibodies directly in the serum with ELISA is not as helpful as a patient who has not gotten rituximab. You're more likely to have lower levels of those autoantibodies, even though there might be still autoimmunity at play.
But and Huiting, just to expand a bit further on your question, I think we generally look for a concordance between C-ANCA and PR3 and P-ANCA and anti-MPO. Sometimes there's discordance, for example, in drug-induced processes. And then there also can be, ANCA negative cases as well. So the absence of the PR3 positivity, even without the prior rituximab exposure, does not exclude GPA for me, if that wasn't too many double negatives.
I think you both did a great job to help us to understand, because there's so many times that we have some positive and negative autoantibodies that we don't understand what happened. So that's a really good teaching point about the rituximab, and just to take it under consideration when we see a patient who's taking this medication, and then we look for the autoantibody. So that's a great teaching point. So Franco, we are ready to have maybe more details about this case.
Perfect. So I have two more aliquots. This is the one before the two more aliquots. So we got some imaging on this one. So we got a CT chest that showed multiple small bilateral lung nodules with bilateral pleural effusions. a CT abdomen and pelvis that was pretty much unremarkable. No problems with the kidneys on the CT abdomen and pelvis. MRI of the orbits only shows soft tissue swelling on the periorbital area without muscle involvement on the MRI. His creatinine jumped to 8 on the following days. So nephrology got involved, and we got a kidney biopsy. Kidney biopsy showed glomerulosclerosis, two interstitial scarring, negative immunofluorescence, and no evidence of vasculitis. The patient got like a construct of GPA, got methylprednisolone, aggressive fluid resuscitation, and the creatinine improved gradually. And he was discharged with plans for a steroid taper and plans to resume rituximab. However, the patient came back. And this time the patient came back with acute hypoxic respiratory failure. SpO2 on that time was in the 90s with 5 liters. And he was transferred to the MICU in the setting of this. And I think I can stop there.
Wow. So, Michael, I think earlier in the case you were thinking about maybe possible kidney biopsy. Is this something that you are looking for with the findings, or you were thinking about something else with your possible differential diagnosis? And what can you interpret with this kidney biopsy and also with the imaging findings?
Well, if there were going to be evidence of GPA in the kidney, what we'd be looking for is usually a crescentic process, often necrotizing, glomerular nephritis, and which can be focal and segmental. But we didn't see that here, despite the really marked creatinine elevation. So, and usually in the ANCA-associated vasculitides, it's what we call pauci immune. And I feel like that was one of those buzzwords that I learned studying for step 1 and never really understood. But basically, it just means that in contrast to, for example, renal disease in lupus, where you have significant immunofluorescence deposition, you really have sort of scant immunofluorescence or very minimal. So that's what they mean by pauci immune. So I am surprised by the findings with the degree of scarring and no evidence of vasculitis. The CT chest and with both nodules and pleural effusions, and now the patient returning with acute hypoxemic respiratory failure is certainly concerning. And I'm wondering if this patient's going to be able to tolerate a bronchoscopy to see if there's any sampling we can do to look for infection, and including less common infections that you would expect in an immunocompromised host such as PJP, but as well as looking to see if there's any evidence of diffuse alveolar hemorrhage, which would be a manifestation, a pulmonary manifestation of the associated vasculitides, particularly GPA. That could cause a rapid respiratory decline. So, and then I'm also just wondering, I think the troponin was fine, but curious just about this gentleman's cardiac function. I'd want a BNP, probably an echo, if he's decompensating to this degree, just to make sure there's no component there that's contributing.
Yeah, I'm wondering, Franco, the timeline of leaving the hospital, what steroid dose the patient was on, maybe when they came back, and how long it was after they left the hospital and then came back.
So he got the pulse dose methylpred while he was on the hospital. Then he started 50 of prednisone. Then the plan was to taper by 10 every 2 weeks. And after 2 weeks, he came back when he was on 40 with this 40 of prednisone. He got this acute hypoxic respiratory failure. Troponins were fine on admission. The echo was also fine. I mean, troponins were like mildly elevated, but not to the degree to think about an STEMI or anything, and the echo was also fine.
Yeah, that's a pretty good dose of steroids to be on to come back. With if it was diffuse alveolar hemorrhage or another manifestation of his autoimmune disease. It's obviously something to consider when we're considering the differential at this point, whether this patient has an infection or whether it's worsening of an autoimmune disease. But it doesn't rule one in or one out. I was going to say something else. Oh yeah, about the kidney biopsy. I agree with everything Michael said. The fact that the read glomerulosclerosis and scarring, tells me that this patient's kidney injury is not as acute as we may have thought it was. This has probably been going on for some time, weeks, maybe months before. I don't know when that baseline creatinine of 0.8 was taken, but certainly that biopsy read tells me that the patient's had kidney disease for a long time, and that still might be GPA or might be ANCA vasculitis. It's just been brewing for a while.
I think now is a good time for Franco to maybe review the final diagnosis. But before that, Michael and Brendan, do you have other differential diagnosis that you wanted to consider before Franco reviews the diagnosis?
Well, I think we've been talking about GPA a lot, and that's because this patient has periorbital swelling, has fevers and elevated inflammatory markers, has acute kidney injury, has mononeuritis, although maybe I didn't hear an EMG, so I guess we don't have EMG confirmed mononeuritis. So that whole syndrome definitely fits with GPA. Those are all common manifestations of GPA. Vexus has been thrown around, and Vexus is, as Michael stated earlier, kind of a disease defined by a somatic genetic mutation. And I want to say like 10 to 20% of the patients with that mutation, they develop a vasculitis, including ANCA vasculitis. So Vexus and GPA don't need to be two mutually exclusive things in one patient. And then other differentials, I mean, infection is still on the differential, especially the fact that this patient got worse after, being treated with steroids and things like that. So it's hard to think of like infection off the top of my head that could kind of tie this all together, but certainly viral, fungal, mycobacterial infections can do a lot of weird things. And certainly when a patient is this sick, you're looking for help from anybody in the hospital. So I think infectious disease would be a reasonable person to talk to. Michael, I don't know if you have anything else to add.
Well, yeah, I agree that, before we would escalate therapy, we'd want to exclude an infection, especially considering that the patient decompensated despite recent escalations in immunosuppression. So that's a bit of a red flag. So either we weren't doing enough, or two things are going on, or we have the wrong diagnosis. So the other kind of category disease that we haven't really talked about would be malignancy. And I'm not sure where I would start to unpack that. But just something that I would explore a little bit more if things are not going as planned. I'm not aware of this patient having any adenopathy, for example. You can get periorbital swelling in for example, parasitic disease, which would be something to consider as well. But I'm not aware of any. I think on the diff there were no eosinophils, but I don't recall if the patient was on prednisone at the time. So those are just other things to think about. But I think still I'd be going after a bronchoscopy, since this patient is now quite sick in the MICU. And then maybe there would be Vexus testing cooking from the prior admission. But Brendan, anything else that you would be doing now?
I'm at the limits of my medical knowledge.
Calling for help, I guess. Yeah.
Yeah, I think we are all this way. We're feeling the same. Every time that Franco brings us a case, it's always like, oh my God, what should we do? So we always think about like in this case, we will ask everybody in the hospital to join us to
Right.
just try to think about. So Franco, please tell us what is the final diagnosis?
So the patient actually, for this episode of acute hypoxic respiratory failure, he tested positive with the urine antigen for Legionella, so he got treated for Legionella pneumonia. Then there was actually for the construct of having atypical findings on the kidney biopsy. Also, we are kind of like discordance of the serology despite with the rituximab, and also with the macrocytosis that was actually worse on this patient when he got readmitted. And being an elderly male as well. So a Bexas test was cooking as well, and that one came back positive for UBA1 mutation on the p-methionine 4 threonine spot there. This patient got diagnosed with Bexas as a mimicker of GPA. Unfortunately, his oxygen requirements kind of like increased, and the family elected, and he elected to be transitioned to hospice. But it was a case of Bexas.
Oh wow. So what a twist. So I'm gonna give Michael and Brandon a couple minutes to think about this, about maybe a reflection about this case and maybe some 2 or 3 teaching points, okay? And I will just pass to Franco the mic to Franco just to ask him how were you feeling about when you took care of this patient. I really wanted to know what is your thought process, how your team got to this diagnosis. Tell us, guide us through this, Franco.
So I think the experience with this patient as like when I was like in the service, it was my first time hearing about Bexas actually as well. Um, just to be kind of like open-minded that a lot of the rheumatologic conditions we are kind of like with advance in science, we are thinking more like in a pathogenic features, like knowing about more the pathways, knowing more what it's happening. Some diseases are gonna have an overlap with heme, some others gonna have an overlap with IV. I think keeping that mind broad that things happen for a reason, and things like we know like have more knowledge about thinking about what is the exact mechanism working, and then there might be a lot of patients that have undiagnosed cases or like difficult cases that the answer is actually on the genes, and actually looking big into the science and the whole process about knowing how Bexas was discovered, how that advanced on the NIH, and then how we can actually test for that was kind of like a good remembrance about how much we still need to learn and how much we are here to kind of like advance in science and help our patients. So I think that's one of a bigger reflection of this patient. And always the reflection that medicine is a team sport. Lots of heads were thinking about this patient, even from the admission, the recurrence admission, getting him on the outpatient while also getting him the help to get readmitted to the hospital, and all the minds like ID, him, derm, everybody. So medicine is a team sport, and I think that's the way we kind of like deal with all those things and manage the uncertainty in medicine. Just a bunch of people thinking about somebody and having the best intention to treat them. I think is one of the most important reflections as well.
Well, Franco, thank you so much for the reflection. And the patient was so lucky to have you as a part of the care team because it was a very, very challenging case. And I'm glad that Michael and Brandon helped us to guide us through this case and gave us so many differential diagnoses, and their clinical reasoning was amazing. So I'm going to pass the mic back to Michael and Brandon to for the final reflection and maybe 2 or 3 teaching points.
I'm happy to start, if that's all right, Brennan. Franco, fantastic case. We're super excited to have you in rheumatology here very soon. So, you know, So I'd say that generally cytopenias in vasculitis are less common. If you ever see a patient with suspected vasculitis who has cytopenias, be it leukopenia, thrombocytopenia, that itself is a bit of a red flag. So usually we would see a normocytic anemia and a thrombocytosis, and then maybe a leukocytosis or normal white blood cell count. And I think with the discovery of VEXIS, now that if you see a patient with an older gentleman in particular with a macrocytosis or thrombocytopenia, especially if they've ever had auricular chondritis, meaning swelling of the ear, then the pretest probability of VEXIS is very high. That's one of the reasons that rheumatology is so fascinating, is that our understanding of the disease spectrum of diseases is completely changed. If you look at the Rheum Secrets is one of our favorite Rheum resources in terms of textbooks. And in the version I have, they talk about relapsing polychondritis with associated myodysplastic syndrome, but at the time they didn't know about VEXIS. And we now know that that particular subset of patients who have been diagnosed with relapsing polychondritis and have features of these cytopenias and myodysplasia are largely VEXIS. So it's really fascinating, and there's so much more to learn, and these kind of cases are the reason that I love rheumatology so much. So fantastic case. Thank you for having me. Brendan, anything you want to add?
Yeah, I mean, that was a great kind of summary of the major teaching points. To me, the main takeaway from this case is to just look at the top left corner of the screen at the patient's age, and the fact that it's a male, 77-year-old male. This is an X-linked somatic mutation. That means it happens in old males. So anytime you have a patient like this where a lot of weird stuff is going on, and maybe the patient has vasculitis, maybe they don't have vasculitis, they have cytopenias, VEXIS is on the differential. So I'm usually, when I was on the consult service as a first-year fellow, I was always invoking VEXIS, thinking like, okay, I don't really know what's going on, but we can just send the mutation. And usually it was not VEXIS, but I encourage anybody to just invoke VEXIS, because it's a disease we're still learning a lot about. It's kind of flipped the paradigm of medicine, right? We usually define diseases by a clinical syndrome of symptoms and signs and findings. And VEXIS is kind of like we're defining the disease by the genetic mutation, and we're figuring out the clinical signs and symptoms afterwards. So it's kind of a weird thing, and it's all still very new. And I've only seen a handful of patients with it. But this was a great case, Franco. Thank you for sharing it with us. I learned a ton, and I hope you all did too.
Yeah, I think we all learned so much from both of you, and of course, Franco, for presenting the case. Thanks again, Michael and Brandon, for all the teaching. And thank you, everybody, for joining this session. And I look forward to see you guys next time. Have a good night. Bye.